This program is brought to you by Emory University.
Well, good morning, everybody. Happy Friday morning. Welcome to another Friday morning Fellows Conference. We're winding down here our last month. These will go through the end of May, and then we'll take a little break for the summer. But I want to introduce our speaker this morning, Alexander Vakili. Many of you probably already know our speaker. He's Georgia born and bred, from St. Simon's Island, Georgia Tech undergrad, Mercer for medical school, and did his residency here at Emory. He's now finishing his first year as a clinical track fellow. He's going to talk to us today about something I don't think I know too much about, and looking forward to hearing about extended reality. So Alexander, take it away.
Thank you, Dr. Williams. I appreciate that. And I hope everybody can hear me okay. So today I picked a topic called extended reality, envisioning the future of cardiology. Thought it would be something different, and it fits along lines with some of my undergraduate work in biomedical engineering. I have an interest in health technology, so let's get started. I have no financial disclosures. I'm sure all of us fellows wish we did, but at this point, not yet. Going through some of the objectives that we have lined out today, I want to make sure that we're able to define the spectrum of extended reality. What is extended reality? To review the applications of extended reality in the practice of medicine, as well as the practice of cardiology, and then as well to identify and assess current limitations and ethical implications of XR. So at the beginning, let's talk about the spectrum of extended reality. What exactly is it? It refers to essentially experiences that blur the line between the real world and the simulated world. It's a collective term to represent these different immersive technologies that have come out that include different kind of visual cues, audio cues, and now even kind of smell and haptic feedback as well. So you get some touch component as well. So starting on the left, we'll start with kind of augmented reality, which is essentially baby XR. So what that does is you're able to use a secondary device and display some type of static image, or even sometimes it can be dynamic imaging over the physical environment. That can integrate into the real environment itself. Mixed reality is essentially where that middle ground where you're interacting with responsive virtual elements. So you can interact with both the object and the object can interact with you. And then virtual reality is the far end of the spectrum where you're essentially fully immersed into an interactive digitally generated environment. I have some pictures right here, as well as the same definition for augmented reality. On the top left, this is one of probably the most popular augmented reality applications that we've got. Pokemon Go came out a few years back, and it kind of took the trend. Essentially, you're using your cell phone, you'll use the camera, and you're able to display different Pokemon, different characters, different game aspects into your real world life. Using different maps, you're able to go locate and find these objects. And that was one of the first big applications that I think came to the consumer world. Google Glass, I think, is something that we've all kind of seen in the news, but the application and the kind of uptake of it wasn't as strong as we kind of hoped for. Essentially, you'd be able to use this technology to display additional information using that camera that's on the top right of her eye and those glasses. And then here's a proposed application where you're able to use the same type of augmented reality, but in a catheterization lab where you're able to display the vasculature, as well as you're able to display possibly calcifications in the vasculature that can help guide your procedure. And then you can see in part C, you're able to see some vital signs, able to see the EKG tracing, as well as sometimes even able to see further kind of further inputs that you're interested in. Mixed reality, this is a little bit more of a complicated kind of term. I know it's the middle ground. It's essentially where the virtual world is imposed on the real world view and you're able to interact with both. Looking at the three objects that we have up here, you can use it for either anatomy. We'll talk about the applications for different procedures, but then also in the non-medical field, you can see on the top right, Ford is using this technology to essentially help them in creating their prototypes for their automobiles without having to essentially build out their designs manually every single time, which can save them a lot of money, makes it a lot more efficient for them to do this. So the uptake is pretty strong. And then virtual reality, this is the one that I think we all think about. You put on these goggles. This is the Oculus Quest in the center, and you're able to fully get into that 3D experience. On the left is commonly used is for video games, and then on the right is a proposed option for thinking about, can we use this for training? Can we use this to kind of simulate the catheterization lab and kind of walk trainees through this to make sure that they're prepared for when it actually comes to taking care of patients? So now that we kind of understand a bit of what the spectrum of extended reality is and what the components are, we can talk about the current applications that are there in the practice of medicine and cardiology. This talk was kind of triggered because there was a really good state-of-the-art review that came out a few months ago in JACC, where they go over the existing applications of VR and AR and how this interacts with different patients as well as different healthcare providers. And so you can see this diagram. They essentially can show you that, they can show you that you can use this for teaching, as well as you can use this for direct visualization of the vital signs. You can use this they're using it for CPR. We'll talk a little bit more about what this is, and I don't want to spoil too much more, but here this table demonstrates how there's kind of a split between, are these applications primarily going to be used for the physician or the healthcare provider in general, or are they going to be used for the patient? And you can see that there's still good aims where you can focus on education for the providers, you can focus on planning for procedures and performing the procedures actually as well. And then for patients, focusing on their education for what's going on with their health at the time, helping distract them through these difficult procedures that they have to go through or when they're in the ICU, and then treatment. So you can also use this for rehabilitation. We'll start with the applications that are physician or healthcare provider oriented. So this is one of the common ones that comes to mind. This is the Stanford Virtual Heart Project. This was stemmed out of their pediatric hospital and their research labs with collaboration with a company called Lighthouse. This video is a little laggy. I apologize for that. But essentially, what it's trying to demonstrate is that, and what their goals were, is to try to help families better understand their child's cardiovascular pathophysiology. So these children have complex congenital heart disease. They're having to undergo possibly future interventions, future surgeries, and this can help educate them as to what's going on. I don't know how many times I've admitted a patient from the congenital clinic to the heart failure service or to the HERS service, and I've tried to essentially explain what's going on to the families, and I met with blank stares when I show them my 2D pencil sketch of what I think is going on. And so the aim of this is to try to help expand on those drawings, expand on they're using plastic models that we have that are difficult to carry around the hospital. And they even, some people are using 3D printed models of patient-specific cardiac anatomy. However, those are static representations of what's going on. They're not dynamic. You're not able to kind of help really engage the family. And this is being used right now as well. Initially, it was for the families, but it's being used with the Stanford medical students to help teach them the different complexities of congenital heart disease. This is another application as well. This is holoanatomy. This is stemmed out of Case Western Reserve. They use this holographic anatomy program. So they use the HoloLens, which is made by Microsoft, that you can see that they're wearing in the top picture. Essentially, this projects out the image where you're able to display different types of anatomies. You can have different layers. This video is kind of lagging, and I apologize for that. But essentially, what it's trying to demonstrate is that you can fully interact with this skeleton. You can interact with the muscle components, the nerve components, the organs. You can use different features that you can activate, essentially what modules that you want to learn from. And you can focus on those different aspects. And one of the thoughts is that this can be a helpful supplement to the traditional anatomy labs that we go through, the anatomy lectures that we have, the PowerPoint presentations and the textbooks, to really give that three-dimensional kind of learning to our students. So what they did was they had a small kind of study of their own. They had about 170, I think, out of about 180 of their first year medical students that volunteered for this. And they compared either a traditional anatomy lecture and dissection lab versus doing supplemental virtual reality dissections through different sections of the thorax, the abdomen, pelvis, and perineum. What they did was they did some pre and post test kind of surveys, reviews on a 5-point scale. And what they looked at was they were saying before, what was your comfort level with material? You've looked at the traditional methods. It's about 2.95 out of 5. Preparedness, about 2.61. This is prior to their final examination. And then post this review, which was essentially what you're seeing in the bottom video that's playing, how did they feel? Did they feel like they learned anything additional? And you can see that the amount learned was about 3.56. The enthusiasm level was about 4.01. One of the limitations to this kind of small study that they had was that they don't have objective data as to what the actual scoring on the examinations, how that changed, how that's going to play a role. So I think that we need to create more objective evaluations of how mixed reality, extended reality is going to play a role. This is a big role. This is something that's happening a lot in Europe as well as the United States is, I think, trying to pick up the AHA, essentially VR enhanced CPR training. So the AHA trains over 20 million people yearly in CPR skills. This is something that a lot of times we watch videos on the internet. We have to go to these physical, essentially sessions where we're watching either lectures, we're performing the CPR on the dummies. But this is how can we use virtual reality to bridge that gap, to improve that gap, and to help with our retention of what we're learning. So kind of stemming out of Stanford, they also had a group of about 120 middle school, high school students, both in California and both in Florida, where they looked at the pre-virtual reality and post-virtual reality training evaluation for CPR. And you can see this table in the bottom left that demonstrates essentially what they were looking at, which was compression rate, making sure that you hit your target goal of about 100 to 120, the depth that you need to get to, as well as the hand position related to the sternum, and then are you allowing full recoil? And you can see here that there's a significant difference that they found between the compression rate, the compression depth, as well as the hand position from target. And they looked at a survey afterwards to see how these students felt. About 79% of the students that already had previous CPR training felt like this was more effective and that it helped encourage their learning. On the right side, you can see a video playing that's essentially a sample of what this could look like. So essentially, you put on this VR headset, you interact with this 3D environment. Right here, they're showing you kind of how to avoid different psychological blocks. You go through different steps, you're looking at vital signs, and you're really trying to essentially practice to make perfect so that when your patient needs you, you're there for them. At the top, kind of talk about, there's a small randomized trial out of Spain where they looked at 50 people that completed training through virtual reality and then some through control where they had routine education, and they did a theory test, and that you can see there's a significant difference between the virtual reality group scoring higher at 9.3 on average versus 7.8. The compressions per minute were higher at 98 versus 81, which is significant as well. And then from a depth perspective of how good your compressions are, the quality, that was also significant. Italy also has a few programs that are coming out where they're kind of focusing on this. But I think this is a really easy way for us to incorporate this technology. And you can see how realistic and immersive that this is. Something else for education is the setup of an ECMO machine. So they have these CardioHelp ECMO devices. They're complex to set up. You have different either technologists that are doing it, anesthesiologists, residents, fellows, trainees, hospital providers that need coaching on this. They need to learn how to do this, especially in critical situations. And so what this environment can do is essentially help provide digital coaching, help walk you through the steps, so that way you don't have to necessarily be in the hospital to have all that equipment around. You don't have to use up this expensive equipment. You can just go through the steps. And then maybe after you've done your virtual training, you can actually do physical training and you can gain more from it. one of the things that I think could be really helpful, and you can see in the bottom right view, we as fellows come in quite often overnight to do stat echoes, and a lot of times the image quality that we see is, this is a fellow lecture, please clinically correlate. And so you can see here that Butterfly is kind of in the works of developing something with augmented reality that you can essentially use your cell phone camera, and it will help guide you to show you which views that you're able to obtain, like this periscope long view, and which direction to turn the probe, where to position it. I think that this could be a really good area for growth, because not only can it improve kind of the fellows learning, but then it can also improve hopefully quality of care for what our patients are achieving, because you have fellows that are coming in July that are already kind of a step ahead of others. This, I think, can be also applied to different procedures, catheterizations. We don't do a lot of EP procedures, but I think that there's a lot of role for possibly practicing this, focusing on this, learning more to minimize kind of the risks of our procedures. All right, so procedural planning. So trying to figure out how we can use this to plan actual procedures, not just education. So right now, whenever we have interventionalists or electrophysiologists, anyone doing these procedures, it relies heavily on the ability to take a 2D representation of the heart, the anatomy, and then reconstruct this into a 3-dimensional space, and just figure out exactly how you're going to best use your techniques to essentially do an intervention, put in a heart valve, do an ablation. And this video down here is from University of Washington, where essentially they're helping with a congenital patient that has, I can't remember, I'm sorry, exactly which intervention that he's getting, but essentially this is a pre-procedural planning that they're using different CT imaging that's been kind of imported into this technology so that the interventionist can see exactly where he's heading. One of the things that we need to do is we need to focus on how we're going to fuse these different technologies. So how we're going to take these different 2D images, these CT scans, these MRIs, these TTEs, TEEs, and how we're going to incorporate them into this. There has been work out there that shows, and this is regarding catheterization procedures, is that when you use TEs as well as fluoroscopy, you can get better outcomes for patients. You have less risk of radiation exposure, you have better anatomic definition and visualization for things like transeptal punctures, valve interventions, biopsies, and now we've got like echo-guided pericardiocenteses. This is something that we know is helpful already in the realm of adding echocardiogram to fluoroscopy, but how can we add additional steps like virtual reality? For example, for TAVR, these are some of the things that thinking about how that can help. So identifying optimal landing zones, you can do pre-procedural planning, so make sure that you understand the valve morphology, where exactly you're going with the stent, kind of where you are in relationship to conduction systems, where you are in relationship to coronary artery ostia, ways to help avoid complications down the road. MitraClip, this could be helpful, almost like a flight simulator. As you think of, you take iterative attempts, you just keep practicing to figure out where exactly is the best location for you to take your transeptal puncture to help avoid adding extra risk to our patients. This is an application that's out right now. It's called True 3D by EchoPixel. Essentially what it does, and I showed this in the initial clip, but it converts the CT and MRIs into these 3-dimensional images. You use a set of polarized glasses to, just like you used to see in 3D movies, the red and the blue. This is obviously a more modern version of that, but you're able to take this image, display it almost as if it's a bit of a hologram, and you're able to use a handheld wand to essentially walk you through different slices, different anatomy. There are some pediatric cardiac surgeons at Stanford that have been talking about how this could be helpful in trying to incorporate this into their surgeries to find out, make sure that they have the best approach that they need to have, understand the anatomy the most, and help minimize time that's spent intraoperatively trying to locate that anatomy. There was an abstract out of Stanford. I don't think that the paper ever got published back in 2013, but they essentially looked at, it was pre-surgical evaluation to visualize arteries in children with pulmonary atresia with major aortopulmonary collateral arteries. And so the reference test that they used was catheter angiography. And then what they did was they took 9 newborns, they had all of their images evaluated, They had a lot of different vessel to lung segment combinations that they were trying to evaluate for and make sure that they had accuracy of where each vessel was going to what segment. And you can see that from the tomography, the typical kind of traditional imaging modality that we have is about 91%. We're able to get accuracy there. And then for the true 3D technology that they utilized, it was similar, it was 91%. One of the secondary objectives of that was to try to evaluate the interpretation time that it took for these different cardiac imagers or interventionalists to evaluate. And it looked like it was about 22 minutes on average for the tomographic views, as well as the true 3D was about 13 minutes, which is a significant difference in the amount of time that it took. So you can see that the interpretation time is benefited. It's faster. We can be a little more efficient with this. Obviously, there's still more work that needs to be done. This was small, kind of more of like a proof of concept type of trial, but this is a way I think that we can advance our speed in reading these complex images. So how can we use this technology intraprocedurally? This is just a sample clip that we'll kind of walk through what exactly is going on, but this is in an EP lab where you're able to, he's wearing the Microsoft HoloLens, where you're able to see different controls here on the right side that you're able to interact with and kind of focus on. You can use these without using any other kind of device or any kind of other technology. A lot of these are hand gesture based technology so that you can maintain sterility, which is extremely important. And then the diagram, the display of what you're looking at right here on the left side right here can be shared not only with yourself, but you can also have the different staff that's in the room with you kind of look at that. They can add to it if you give them permissions, kind of try to help expedite the procedure or make sure that you get the most anatomically accurate representation of what you want. This is out of Washington University in St. Louis. It's a company that has been commercialized called Senti AR. It's called Elvis is one of the technologies, enhanced electrophysiology visualization and interaction system. What this is essentially they use a combination of electroanatomic mapping. They use TE, intracardiac echocardiography to try to create these three-dimensional kind of cardiac geometries that represent the mapping that you're interested in. And then you can see here that you can also localize the catheter based on this technology, which is really nice. The inputs for it, you can see here, are the traditional electroanatomic mapping systems, as well as the CT and MRI. And there's kind of third-party products that kind of bridge the gap between those two so that you can create these 3D models. But this was essentially kind of proof of concept that they were focusing on, like in the procedure itself live. And like I said, direct control without breaking sterility during the procedure. You also get some sharing functionality. Here, this is another kind of group that was focusing on similarly, how can you incorporate this into visualization of myocardial scar? So they used the same kind of technology. However, they did the cardiac MRIs. They would look, this was a swine model where they would essentially induce infarction. They would represent the late gadolinium enhancement scar. They would create these 3D scar rendering models, and they would take it through this framework. Essentially, it's called Film Box, and then through a 3D viewer beta, which is essentially kind of a developer product put out by Microsoft, and they would create this 3D holographic visualization that would allow you to have touchless integration. So you can see that there's potential use in the electrophysiology community. Now, from a kind of interventional structural kind of coronary vascular standpoint, there was a group out of Israel actually that did a feasibility study using this technology, RealView. And so what that would do is actually, without the assistance of needing an extra set of extra headset, special glasses, or anything along those lines, you would have this holographic image that's displayed off of this projector that's right here in the cath lab. So what they were able to do is create these real-time interactive 3D models using 3D rotational angiography. Here, they were able to use 3D TE. And the primary objective of this kind of small study was to essentially show that you're able to accurately identify all of the anatomic landmarks that you need to look at. So kind of anatomy and size of the ASD, where is the position of the septum, how is it related to kind of the SCC, IVC, and are there any additional defects that are there? And then also using it to evaluate kind of once you use an ASD closure device, is there any residual leak there? Secondary outcomes for this were usability of interactions with the images. So how convenient is it? How easy is it? Is it difficult to use? We're not going to use anything that makes our lives harder and that take away from patient care. So that's one of the things that they focused on. It's only 8 patients. Like I said, they had 4 different observers. They were pediatric cardiologists, and then they had cardiac imagers that were experts in this field. And essentially, they successfully identified all of the landmarks that had kind of been pre-laid out prior to the study starting, without having to essentially look at the other data. So they would either look at this, they would look at these 3D representation, these holograms, or they would look at the 3D TEs, and it was 100%. They were able to find out where every anatomic landmark was. And they scored it as a 5 out of 5 for very easily to use. You can see that you can either point to it with your finger, or you can use a extra product to actually interact with the imaging itself. Intraprocedurally, so this is something that I thought was interesting. It was about transapical off-pump mitral valve repairs using a neocord for our surgical colleagues. They used a porcine model. This was back in 2012. And essentially what they were trying to identify is that how many successful attempts would you have when you were approaching this, when you're trying to do the intervention using either TE alone, or you would use AR guided technology. You can see here, this is kind of the image that you would see as the surgeon. You would see your device here that is implanting your neocord. You have 2 different axes. One is the angle of which your jaw is opening. The other is the angle of which your neocord is heading towards the posterior mitral leaflet. And then you can see that this red ring represents the mitral valve. The blue ring represents the aortic valve. This picture, I think, is really, really cool to see. This is essentially kind of more novice surgeons that are using the product. This is with TE guidance alone. You can see that every different color is a different attempt from a surgeon. You can see how many different kind of passes it takes. And this puts you would think that substantial risk for different types of injury. And this is when those novice or intermediate surgeons actually use the AR guided technology as well. This is essentially an expert physician or surgeon that's been doing this regularly, this procedure. You can see that even they sometimes go into the LVOT, sometimes they even get caught under the leaflets, and that when they use the AR guided, essentially a straight shot. This is a table that represents the possible complications that they may have seen, that you may have faced in this, because this was a porcine model. Obviously, this wasn't in patients, but you can see that there's injury potential to the aortic valve, different leaflets, the atria, and then as well, you just fail and you're unable to do this and complete the procedure. You can see that with AR guidance, there's really only the chance that it could have issues with the posterior leaflet of the LV free wall. And so that was a significant difference. And then as well, they looked at the distance errors from midline. So using TE alone, you can see the difference there in millimeters, 17 millimeters versus 5.2. And then the total navigation time that it took to make sure that they were able to get to the leaflet is significantly different, as well as the total path length. So how long and how much distance they were traversing. And like I said earlier, the risk that has procedurally. We'll take a step for how these applications can be used in a patient-oriented manner. So regarding education, so I know that we had mentioned the Stanford Virtual Heart Project initially, and this was, like I said, this was the first goal of the project, was to make sure that they're able to educate families and patients on their complex congenital care. So that's one aspect you can see in the top. This is not that exact same image or the exact same product, but this is a different product, but you can see that the child's able to interact. You can learn, you can essentially interact in a clinic appointment with your patients and show them all these images and have them understand better than just looking at a 2-dimensional black and white echocardiogram. Medical training. And so this was a very small kind of study that essentially they were looking to see how patients were able to prime and install their peritoneal dialysis setups using a step-by-step VR tutorial. And one of the thoughts is that this could try to help reduce infection rates in patients that have to set this up at home because they know the steps, they're able to take better care, cleaner care. Thinking about other applications for that, I just finished heart failure and we have our patients that have to do dressing changes, or they have people come to do dressing changes for different LVADs, PICC lines, and try to make sure that they can minimize the infectious risk there and hopefully keep them out of the hospital. This last component, this is a small study kind of out of the Netherlands. It was a non-randomized observational study. They only used 22 patients, but essentially they looked at patients that had just had an MI. And what they wanted to do is they wanted to see, is their the knowledge about statins, is their adherence to statins appropriate? And how does that change based on traditional kind of using a booklet face-to-face when talking to a nurse versus using virtual reality augmented education. And they did a test of statin knowledge pre and post. About 83% of the virtual reality patients improved their statin knowledge. You can see that the score pre-test was about 13 out of 50, which is very low. And then post-test score is 21 over 50, which still doesn't seem like that's what I exactly want my patients to take away, but it's a step in the right direction. You can see that the control group, they only took kind of the post-test after their traditional learning. They scored about 6 out of 50. One of the limitations to this that you can see kind of in their methods is that they actually included for the control group of patients that they were allowed to have their MI 1 month, 6 months, or 12 months in the past. And so unclear how that plays a role because the VR group, they had to have their MI within a 1 month period. So I'm not sure if kind of bias is related to that or not, but it's a step in the right direction, I think. And then this last thing, procedural consent and education. So this is a video of a gentleman that's about to undergo a procedure, and he can walk through what it's going to look like when he's in the lab. He can introduce and he can meet all the different staff, the physicians, surgeons. I know that when we have our patients come to the cath lab, for example, we only have a few minutes in there to consent the patient in the holding area, and then they're essentially rushed back to the catheterization lab, and that can provide and cause undue anxiety that we don't need to have for our patients. So I think that this could be a good step in helping educate our patients. They can understand the procedures more and they can have better informed consent. Speaking of informed consent, this is kind of off topic of cardiology, but I thought this was really interesting as how they were some thoughts out of George Washington, I'm sorry, to try to get patients to get vaccinated, looking at this virtual representation of COVID lung. So showing this to our patients that haven't gotten vaccines and saying, hey, I know that you've seen this online, you've talked to your family, and you may not have concern about this, but this could be something that happens to you, and this could have long-term side effects. And I think that this in the future could help increase vaccination rates if we need to, increase adherence to other recommended medical interventions. When our patients just get stents and we need to have them on DAP therapy, making sure that they fully understand what's going on. You could show them essentially a thrombosed stent and kind of explain to them what the implications of that are. And hopefully that would essentially resonate with them better than just the few minutes that we have to talk to them in the hospital or that we have in our clinics. So also, how can we use this for our patients in the realm of distracting them? So the ICU environment, the cath lab environment, the hybrid ORs, these are stressful environments. These patients, they get anxiety, they develop delirium, they get bored, they sit in there for a really long time. Just imagining the heart transplant patients that are waiting in the CCU just to get their lucky day, and kind of what they're doing to keep their mind engaged, to keep them active, and how can we come up with stuff to help our patients. So there was a small prospective randomized pilot study in Germany where they looked at the feasibility and safety of virtual reality in patients that were getting transfemoral TAVRs undergoing conscious sedation. So they had 32 patients, 16 of them underwent the virtual reality, and essentially they would select these relaxing videos, they would watch them. They would normally watch the video for about 30 minutes. That was a median duration that they would watch it for, compared to a control group of 16 that did not have that. And this is interesting to me, is that their median age for this was 83. So I know that we always think of like new technologies as being only for younger adults, but this is something that they focused on a group that was at a higher age, and they looked at the outcomes of how that changed their anxiety. Were they comfortable with using this? And they used a visual analog scale of 0 to 10, pre and post, to represent their anxiety levels, their pain levels. And based on the VR group versus the control group, post TAVR, there was a score about 2 on the scale of anxiety versus 5 for the control group, which was significantly different. And out of that VR group, 94% of them would use it again during a TAVR procedure, which shows that I don't think age is a limiting factor for these new technologies. This last component is essentially a small study that looked at the healthy patients that they would take into an ICU, and they would measure their vital signs. They would look at a VR group where they were allowed to watch the same type of relaxing videos, and then compare it to kind of how they did previous to that. They didn't have a control group there. What they did to try to help minimize kind of the initial stress of being in the ICU was they would wait 10 minutes, recheck their vital signs, and then compare it to that. And they saw that they had improvement in their heart rate and blood pressure. Oxygenation saturations were the same. But I think that that's something that is limited in the setting of healthy patients, but could be helpful in future cases. This image down here, this is a representation from that study in Germany during the procedure. This is a sample clip of what he's looking at walking through a forest while they're getting access right here. And this is, I believe, at Cedars-Sinai. Treatment. So how can we use this to help treat our patients, not just to help kind of distract them? So it gives us the ability to empower patients that are typically bedridden, they're unable to actively participate, they have physical restraints and limitations, they have cognitive restraints and limitations, and they're staying in the hospital bed essentially for a long period of time, or they're staying in their homes for a long period of time. But how can we get them to engage with the environment? Maybe their home environment is not optimal to that. And so the virtual environment is essentially, you can create whatever you want to create. This is almost like a boardwalk where you have kind of a bit of a circus tent, and patients can essentially stack blocks. They can have a cognitive load here. And I think it's important to incorporate that we can use physical kind of exercise as well as we can use cognitive exercise for them. And the benefit as well is that you can use remote and offsite capabilities. So patients that aren't able to come to all of their rehab appointments, they're unable to get travel for that, they're unable to get transportation, or they're just not interested in that. This is something that you can let them do at home as well. And there are studies right now that are trying to essentially evaluate the safety and efficacy of this. How does this work in the setting of cardiology? What are we doing in the setting of cardiac rehab? I think we all know that cardiac rehab is a class 1A indication. It's a multidisciplinary behavioral lifestyle approach. It's got multiple prongs that you're trying to do. You're trying to improve their cardiorespiratory fitness. You're also trying to educate them on their disease. You're also trying to counsel them on future steps to help prevent things like hospitalizations, prevent things like future cardiac events, and improve their quality of life. And it's something that's extremely underutilized right now. I think there was a big healthcare initiative essentially that was put forth, because I think the utilization was somewhere on the scale of about 20 to 30%. And the goal was to try to get up to about 70% of utilization by 2022. Here you can see this is essentially kind of a sample where you're able to incorporate the exercise training into the physical movement of the hand controllers, as well as ambulating around, walking around, as well as the component of using like an arcade game, that type of mentality, you know, where you want goal-oriented tasks, you want to succeed, you want to get credit for what you're doing, and to incorporate all of that into cardiac rehab to try to motivate patients to adhere more. At the University of Illinois at Chicago, there's a physical therapy rehab program that's essentially creating this clinical arcade. There's a paper out discussing how they're coming out with this. It was just put out last year, and they're talking about coming out within the next year or so, but essentially trying to develop the same outpatient cardiac rehab, but in this gamified kind of scheme. So kind of reviewed the spectrum of extended realities. We've reviewed some applications of extended reality. Now we can kind of talk about some of the current limitations and as well ethical implications of XR. So cyber sickness. So this is very common. This is what people mostly say, is that, you know, I don't think I'll be able to tolerate it. I've heard that friends have worn these VR headsets and I feel like I'll get dizzy, I'll get nauseous, I don't want to throw up, I'll get sick. And while that is a real thing, I think that sometimes we may overestimate that risk. Hollow anatomy, what we showed earlier from Case Western, those 170 students, one of their secondary kind of data points is that they were looking to see side effects. And so 26 out of 170 of students reported that they were having headaches associated with this, but that shortly after removal, that they had resolution of those symptoms. That is high number, I think. And then nausea, eye fatigue, neck strain, that was about 17 out of about 170 of the students. One of the kind of components that goes into this is that everybody is a little bit different. Head size is a little bit different, kind of pupillary distance is a little bit different. And so there were no adjustments made to kind of accommodate for that. And there were no adjustments to the brightness settings. There was no kind of customization for that. So the students may not had the optimal setting for them. And who knows, maybe there could be some benefit if we're able to focus on that. From the study, the German feasibility study for TAVR, of the VR group, like I said, 94% of them would reuse this, and they did not have any more nausea or vomiting than the control group did when they looked at the patients. And then as well as the statin VR trial, they only had 12 patients. They were wearing it for an hour, so extended period of time. However, there were no cyber sickness related complaints to this. Some of the technical issues that I think we're going to face, and this in itself could be an entire, I think, electrical engineering talk. So the head-mounted display in itself can be cumbersome. So looking at the images that we looked at earlier, this could restrict physicians' head motion, peripheral vision, could essentially cut out their field of view and cause them to have discomfort of having to wear these during long procedures. And that's something that we just simply cannot have. They're about the weight of about 1.2 pounds is the weight of about the HoloLens or the Quest that you're wearing on your head. So it's not negligible, but it's still present. Discomfort of the earpieces that are there, as well as absence of visual fixation during head motions that can also create some of this nausea, some of the cyber sickness that you're experiencing. And then ensuring that balancing the augmented reality as well as your real life kind of patient that's standing in front of you, you never want it to obstruct that. So you want to make sure that if something happens, you can always see the patient, you can always intervene on the patient, and that you're not being distracted by this technology. It should be a supplement, it should not be a replacement. Integration of distinct imaging modalities. I think I had mentioned earlier that they have technology that's working on CT, MRI, echocardiography, electrophysiology mapping. However, a lot of that is essentially research labs that are creating these different types of programs that will incorporate these types of images into these 3D renderings. And so there's no standardized kind of program out there that's being used across multiple facilities. So I think focusing on that is going to be very important. And then absence of accurate and verifiable patient tracking limits can limit the accuracy of the image overlay in the case of projector movement. So in that first picture, I was demonstrating the vasculature that can be represented, the calcifications that can be represented on the patient when they're in the cath lab. But if the patient moves or if the projector moves, that's essentially kind of overlaying this onto the patient, then your limits they're offset. And so everything that you're looking at is going to be wrong. So kind of focusing on that, how are we going to improve that? And maybe that's going to rely on just kind of an improvement in technology, hopefully. And then as well, how does this apply to our providers as well as our patients that have hearing or visually impaired? How can we incorporate this in them? Because one of the big things that we want to do is make sure that this is an equitable product that we're able to provide for our patients, a service that we can give them. And we don't want to necessarily kind of cut people out of it just because they have some limitations. So how can we develop technologies to focus on that? Further technical limitations that I think we can have rapid improvement for. I mean, I think we've seen rapid improvement already. This on the right is just 2 clips of video games. Essentially, one is from on the left is from 2002 on the top. You can see the graphics that are available, and then 2020 on the bottom. And then as well as Grand Theft Auto, one of the driving games, you can see on the top 97 versus 2013. And you can just see the advances that we've made in the realm of video gaming. And I will say that a lot of things that I've read show that kind of the entertainment industry, the gaming industry, this is what's boosting this technology. So I think that there's a lot of funding going into it from there, and we can piggyback on the back of that to try to get some of the medical applications optimized. Data transfer speeds, I think, will improve frame rates and latency. When it's too slow, essentially that can play a role into the cyber sickness. So the faster your frame rates, the shorter your latency, the better tolerated it is typically. Vergence and accommodation conflict is a bit of a technical concept that I'm still trying to grasp it, but essentially kind of when you're looking at where these images are displayed, are they too close to you? Are they too far from you? And how your eyes are able to kind of accommodate and deal with that can lead to blurred vision as well as the same symptoms that are related to cyber sickness. Battery capacity is going to be very important. Right now, I think the typical battery capacity is about 2 to 3 hours for these wearables. If you have them plugged in, that's great. But a lot of people, I don't think, want to be wearing heavy battery packs during the procedures. And then cost reduction, we'll go through some of the costs later. But as we can see, a lot of our technologies are getting better, as well as the cost is decreasing. And haptic feedback, this is something I didn't talk about too much. But essentially, it's one of the big limitations that we have in virtual reality is that people say, you know, I want to be able to see the patient. I want to be able to touch the patient. I want to have that feedback when I'm doing my procedure so I can know kind of my intervention. Am I being too forceful? Am I not being too forceful? And so there's technologies out there right now that use different types of gloves that provide haptic feedback. The controllers themselves attempt to do that as well. And then they have very expensive kind of full body suits that will do this, but that's kind of out of the realm of practical application, I think, for us. Ethical considerations. This is very important, I think, because as we're ever advancing, want to make sure that the machines don't take us over and that we don't give up ourselves to the machines. So how is it going to play a role and how is it going to affect human-to-human interactions, human-to-machine interactions due to how immersive this is? I mean, this is, you can be in virtual reality and you can forget about everything else in the world. It can create this distorted reality, which can be harmful in a lot of cases. I mean, we already know that using our cell phones, walking around, being with friends at the dinner table, watching TV, it's already taking away from our human-to-human interactions. We want to make sure that we focus on not allowing that to happen in medicine. Protected health information, so security and privacy. And so we have very strict rules right now about how this data is shared. We want to make sure that our patients trust us. We don't want to allow them to feel like we're just sharing their personal information, their health information, that we're selling it. It's very important that we have kind of frameworks and strategies to help minimize that and ensure that our patients can trust us from there. Authenticity of information provided. I mean, this could be a method to distribute fake news. I mean, something that's very important. You know, you could essentially say, you know, these essential oils will help cure your cancer. And that's something that we need to make sure that we're able to audit that and focus on authenticating the information that's provided. This is all very freely available. A lot of this is downloadable data and downloadable kind of programs. And so I think we need to focus on creating a regulatory community for that, which I'll talk about in a little bit later. And then corrupt usage of technology information. So I think this is extremely important because the biggest thing is that these industries, they don't do things for free. They're going to want to make money off of it. And we have to just focus that, you know, patient is the priority. Like I said, these are some of the same priorities that I've discussed earlier. Virtualist. So this is an interesting concept that was kind of discussed in that state-of-the-art review in Jack that they had referenced, but essentially it would be a physician, surgeon in any specialty that's received additional training in a virtual care model. They're able to manage different remote data points. They're able to understand these different technologies, all the idiosyncrasies. They're able to consider the ethical implications. I mean, this is something that I feel like we're already seeing is that we have these virtual physicians that are able to prescribe medications, make evaluations, do everything over FaceTime, over Skype, over Zoom. And now that our technology is improving, we need to make sure that we're able to keep up with that. I don't think that this necessarily needs to be an entire residency program or fellowship. However, I do think that incorporating it into our present training strategies is very important. I think medical schools can use this at a young age as well. And I mean, I think we're seeing that at a younger and younger age, children are able to kind of interact with these iPhones and these different technologies a lot better than I will say I was when I was a kid. And that's not too far back. So this is kind of some of that framework that, and these are some recommendations that were put out by the Institute of Electrical and Electronics Engineers in their white paper on extended reality in medicine. This is a lot of recommendations, but I think the core things that we need to focus on is developing a framework for good testing, design, as well as reviewing what's out there and keeping kind of track of where we're heading in the landscape of medicine, creating some center of excellence to essentially help validate these products, validate these technologies, simplify distribution, ensure that different hospital systems, different places are able to have equal access at a low cost is extremely important, because we want to make sure that we're equitable in that nature. We want to make sure that technology developers and adopters like ourselves, or different educators, they're able to essentially interact and talk, make sure that that information that is being put out is authentic, make sure that it's always in the best interest of the patient. Adoption of guidelines. So set out guidelines that are put out by, be it the American College of Physicians, AMA, ACC, HA, whatever it be, make sure that people are adopting those guidelines so that we have a structure here. And then when it comes to kind of advancing these technologies, kind of we need to have better structured validation networks. We need to make sure that we're able to create better studies. We have better standardized protocols, so that way we can compare this data, compare these technologies more regularly. And so, because there is such a heterogeneous component to this, there's so many different technologies, there's so many people developing this, we need to make sure that we're able to compare apples to apples. And then as well, creating an ethics framework for it, like I had mentioned earlier. Kind of closing out, so about cost, I know cost is always a big question as to, this technology, how much is it going to cost me? Is it going to be prohibitive to our patients, prohibitive to our clinics, prohibitive to our hospitals? The Oculus Quest, which is down here at the bottom, this is about $299. Sony PlayStation up here. The HTC Vive is just this component that he's wearing right here. This is about $1,400. There are a lot of studies that are essentially trying to use this technology. And the Microsoft HoloLens, a lot more expensive, about $3,500. However, noted by a lot of different groups that this is one of their preferences for using, just due to kind of the incorporation with a lot of the technology available out from Microsoft. Haptics, as I had kind of mentioned, there's a big scale. This is that expensive kind of system that I was talking about. It's from Haptex. They actually don't publish how much it costs. They just say it's 5 figures over $10,000. And it's only kind of a business model right now where they're able to send it to like developers, but not to consumers directly. But there is the cheaper product that's out about $299 that looks like kind of winter gloves that essentially provide you with some of that feedback for about $299. Software is going to be an additional component, because not only hardware, but we have to deal with software. Some of these are free softwares that are available right now. So the VR, CPR trainings that you want to get, I was looking on the app stores, those are available at no cost. However, these things are going to get expensive. These things are going to become proprietary, and we're going to need to be able to figure out how we can afford that in a good way, and then make sure that it's not out of the, it's not cost prohibitive to us, like I had mentioned earlier. So in conclusion, I think that extended reality is something that feels new, but I think that it's something that we need to kind of focus on and develop further so that we can apply it in the future. I think it has a role in assisting both providers as well as patients, and complementing the traditional education kind of methods that we have, textbooks, lectures. I don't think that right now we're at the point where it's a replacement for any of that. As well as supplementing with planning and performing complex cardiovascular interventions like we had talked about. I do think it got a great role in easing patient anxiety, assisting with rehabilitation, and helping our patients that are limited due to kind of transportation issues or physical or cognitive restraints. I think we had talked about the technical challenges that need further work on, and how we need to develop better clinical trials with standardized protocols to focus on this, as well as creating ethical guardrails. And that with remote medical care that we're providing on day, I see patients at Grady still, telehealth visits. How can we possibly use extended reality into those? And so I think there's a lot of exciting things out there. I think we've just kind of hit the tip of the iceberg, but definitely not ready to fully toss everything into it, my whole weight behind it. But I think I'm excited to see where we head. And some of my references, just want to see if you guys have any questions for me. I appreciate your time and attention.
Thank you, Alexander. That was a very good review of a very appropriate and interesting topic. I just have a couple things. One, just a plug quickly for those that haven't seen it. We have a relatively new echo simulator. Speaking of simulators, at Clifton in the echo reading room. With mannequin where you can practice getting transthoracic and transesophageal images. And two, just the promise of simulation, I think, is somewhat unfulfilled at this point. And there's several reasons for that. Obviously, we use it from time to time, and I think some places probably use it more than others. We do here and there. You mentioned a lot of the issues. Upfront costs is often prohibitive in this situation. So having technology that is affordable and readily available, if it's using phones or headsets, that as the price point comes down. And then these things being able, I think the technology becomes obsolete fairly quickly, in these things. So, you get it, you have it, you're excited about it, you use it for a couple of years, and either it gets sort of beat up or it becomes obsolete, and so a bit, sort of upgradability, I think, is an important thing, or adaptability as like times and technology and even like the procedures change, if you're just adapting one particular procedure, it's like, well, can we modify the software as, the way we do AFib ablations or the way we do, mitral percutaneous mitral valve procedures change, so it doesn't become obsolete. So those are just from an educational standpoint, some of the obstacles we've run into sort of through the years doing this.
No, I appreciate that, and I definitely agree with you. I think one of the benefits to this type of technology is the incorporation of software and how those can hopefully continue to evolve and improve. However, we have to make sure that our hardware is able to keep up with it. And so those devices are typically the ones that have to keep up with the frame rates, the latencies, the battery duration. So I think you're absolutely right. Do we really want to spend $10,000 on something that'll be obsolete in a year, just based on how advanced we're becoming with the development of kind of like our semiconductors and kind of the technologies that we have available for us, microchips and everything? Dr. Dicker, I think I see your hand.
Yeah. Just two quick comments. So first, this was a long time ago. I think it was my first year on faculty. We did a very small trial of using a more sophisticated illustration system for before patients went to cath, kind of as part of the consent process. We never published it. We never enrolled a lot of people, but it was interesting. The signals we saw were things like, people felt more comfortable about what they might undergo. They kind of had a sense of being engaged in their care. The reason I raise that is I agree with you that it's important to pursue these tools as communication tools. And it's interesting to think about what the right outcomes are, right? We were sort of hoping people might understand more about their disease. We didn't see any changes in knowledge, but there was sort of a kind of an emotional impact of seeing what they were going to undergo. And so I think it's important to think about how they're going to function and to pursue different uses of these of tools in the communication space. The other thing is that, I just, to me, of the things you mentioned on your conclusion, probably the most important is this notion of really doing good trials of these technologies before they kind of permeate the environment. Obviously, I don't think you mentioned it directly, but the sort of cautionary tale with regard to robotic surgery, where it kind of took off and became an expectation on the part of patients, in part because they thought it was cool and it must be better. And in certain cases, it's not been shown to do anything other than increase cost. And you lead to a bunch of people buying robots for indications where they may or may not be helpful. So I think it's really interesting to think about. So from my perspective, from kind of an ethics perspective, the latter is just super important, that we think about how to roll these things out well in ways that we can really understand the use, so that we can use them in the good ways and not wind up sort of having the expectation be to use them when they may or may not help.
Yeah, I think that's excellent. I appreciate all those comments. And I like the fact that you guys did that with the cath lab. That's something that I kind of mentioned on my rotation, was at least even a video to help walk patients through, to provide, if it's not knowledge about the procedure, at least it helps relieve some of their anxieties that they may have and kind of understand a little bit more of what the expectations are. So I think that's something that, I don't know if we have room for it here at Emory, but I think it would be great to get started at least on a two-dimensional platform for video. But I think as these technologies roll and if they become effective, then I think we can try to incorporate that here.
All right. Well, thank you, Alexander. For the sake of time, I think we'll wrap up here. I encourage everyone to reach out to Alexander personally with your additional thoughts and questions about this talk. And I would encourage everyone to, if you haven't already, look in the comments box. Modele had a couple of nice points that she raised about additional uses for virtual reality / machine learning. So I would encourage you to look at that as well before you log out. So, all right. Well, thank you, everyone. Everybody have a good day. We'll see everybody next Friday morning.
Thank you.
Thank you, sir.
The preceding program is copyrighted by Emory University.